Good morning, everyone. My name is Shahari Beg. I'm a medical student from Oxford, and I'm presenting today on major and unexplained geographical variation in coronary revascularisation practices in England. As I'm sure many of you are aware, there are two broad routes for revascularisation: percutaneous coronary intervention and bypass grafting. As the years have gone on, we've got a better evidence base, and the preferred intervention is governed by a number of factors, including patient preference, comorbidities, and the pattern of disease anatomically. Over the last 10 years, we've seen this quite controversial figure where the PCI to CABG ratio has increased year on year. The reason this is controversial is because there's still a solid evidence basis which suggests that CABG is preferable on both an economic and clinical prognostic basis. Really interesting studies overseas have shown that there's huge variation in the PCI over CABG ratio, even in neighboring towns. So studies in New York, in Canada, and Australia have shown that even within the same city, this ratio is very variable. And what's more, it's not related to patient factors, but it's related to practitioner preference and perhaps perverse incentives. As of yet, no one's assessed this in England, so that's what we sought out to do. What we'd expect is, in a country with a national health service, with this concept of universality, there should be consistent adherence to guidelines, and what there should be is minimal variation, and any variation that exists should be linked to the need rather than practitioner preference. So what we did is we looked at elective PCI rates, ignoring primary PCI, looked at total CABG for each of the 151 PCTs, and we calculated a ratio to indicate what the predominant strategy was. And what we found is quite remarkable was a 13-fold variation across the PCTs. I'll let you just dwell on that figure for a minute. It's just staggering how much variation you see across the board. I think what really typifies the situation at the moment is the fact that you've got at the top there, North Tyneside, performing at about 4.74, whereas only 40 miles away in Darlington is the lowest figure of 0.36. This begs the question, why is there so much variation? And variation can be due to warranted factors such as the patient-related need, and there can also be unwarranted variation. So what we try to do next is determine what is the source of this variation. What this figure shows is that it's very, very unlikely that these changes and these differences have arisen by chance. What we'd expect is if these changes were by chance, 99.8% of the PCTs would sit between the two dashed lines on the outside. And as you can see, there's a lot more variation than that. This is really the take-home message from the talk, I feel. I feel that it's important to emphasize that there's no link between deprivation and the PCI CABG ratio. What we looked at was the index of multiple deprivation, which is quite a robust indicator of socioeconomic status. And we tried to link this with the ratios. On the left-hand side of the screen, you can see the more deprived PCTs. And what you'd expect is, with increased deprivation, there's an increased cardiovascular disease burden. And with that, you'd expect there to be more CABG being performed. And as such, you'd expect an increasing line across the screen. You'd expect some sort of positive correlation. But that's not what we see at all. And the reason this is worrying is it suggests that there are other factors involved rather than just demographics and incidence of disease. And over the last few years, there's been an increased awareness of what some of these factors might be. I'm not going to stand here and speculate over all the possible reasons, because we could be here all morning, but I think individual practitioner choice, the presence of ad hoc PCI, and a lack of informed consent in the field may contribute towards this. And that's something Professor Taggart talked about yesterday, that a lot of patients undergoing PCI are unaware of an alternative, and they're unaware of the real rationale behind PCI as opposed to CABG. What can we do to reduce this variation? I think a three-tiered approach is required. One is mandatory guidelines based on the latest and best evidence. I think come April 1st, the commissioners need to be aware of this unwarranted variation, and in this time of austerity, it's important that there's financial accountability and that all the interventions being performed can be justified. And we've talked a bit about MDTs this morning already, but I think an MDT approach in cardiothoracics is something that we're seeing cropping up everywhere. And I think in cases where we're unsure whether there's a clear indication for PCI or for CABG, this is where the heart team really comes into its own. And I think an open discussion involving the patient's best wishes is probably the future of this field. Thank you very much. Do you have any questions?